So first of all, we have Dr. Amit Sud talking about cancer. Amit is an academic clinical lecturer in genetics and epidemiology at the Institute for Cancer Research and is completing his haematology training at the Royal Marsden Hospital. He's just been awarded a Wellcome Trust Fellowship, yay. And his main research interest is in the germline and somatic genetics of blood cancers, as well as the long-term side effects of cancer therapies.
Thank you very much for that introduction, and it's a great pleasure to speak to you all today on the topic of polygenic scores in cancer. My name's Amit Sud. I'm an academic clinical lecturer in genetics and epidemiology, and I'm a hemato-oncologist as well, working at the Institute of Cancer Research and Royal Marsden Hospital. So the first thing I'd like to say is I've got absolutely no conflicts of interest to declare. I'm not making any money from polygenic scores, and I think that's quite an important point when people talk about polygenic scores. So I'm going to talk about what are polygenic scores, and I'm sure most of you know what they are already, but I'll give a very brief introduction, talk a little bit about risk discrimination and what that means in the context of cancer, and then how polygenic scores might be applied in cancer. So I think a good place to start, however, is in why use polygenic scores in cancer, or why screen in cancer. And this diagram here shows the 5-year net survival in patients diagnosed with colorectal cancer, and it's stratified by stage at diagnosis. And what you can see here very clearly is stage-specific survival rates. And so logically, it would make sense to try and diagnose as many people as possible with colorectal cancer at the earliest stage of their cancer and the evolution of their cancer. And from a more practical point of view, by 2028, the long-term NHS ambition is to diagnose 3/4 of all cancers at stages 1 and 2. So there's clearly a need to have tools and improve how we diagnose cancer and diagnosing it earlier. But it's important to remember that whatever we're doing, whatever we're diagnosing and however we're treating patients, the overall aim is to reduce morbidity and mortality, not necessarily to diagnose more people. So Annika's already touched a little bit about the discourse around polygenic scores, so I've tried to make this cancer specific. This gentleman doesn't need any introduction, and I'm sure you'll remember his quote, which I think was in 2019, and he said that he's at high risk of prostate cancer, and by the age of 75 his risk is almost 15%, and that may have saved his life. Our Future Health, which is recruiting 5 million individuals in the population, have suggested that polygenic scores can change the whole paradigm of healthcare. Genomics PLC have suggested that they can identify people at elevated risk of disease, match them to the right prevention, screening, or treatment pathways. And this is just to give you an example of some of the perhaps informal discussions around polygenic scores in cancer. So these tests are cost effective now, and they're useful. We can rule out colon cancer in people who've got a low polygenic score and save them having an expensive invasive test like a colonoscopy. So this isn't to say any of these are right or wrong, but it's just to give a flavour of the discourse that's around at the moment. And I'm sure you're all familiar with this, but very simply, a polygenic score is the addition of the common genetic variation that contributes to an individual's risk. So you can just see in this diagram here, you've got these little blobs at the bottom, and the orange blobs confer a high risk. So you can see that in the cases with the orange distribution, there's an enrichment of these higher risk alleles or variants compared to the controls or unaffected. And you can see that it's a normal distribution, generally speaking. And in the literature, you'll see lots of different ways the risk discrimination is expressed regarding polygenic scores. you might see relative risks between different percentiles, you might see absolute risks, but one very helpful metric is the detection rate and false positive rate. And that's really a function of these normal distribution curves and how much they overlap. And the detection rate is a proportion of individuals who will develop the disease who have a positive polygenic score. The false positive rate is a proportion of individuals who do not develop disease with a positive polygenic score. So you can see I've been a bit ambiguous about what constitutes positive. That positive can be changed with the threshold wherever you set it, and that determines exactly what you might do to that population that fall higher or lower above that threshold. So the first question is, well, what's the risk discrimination offered by polygenic scores in cancer? So here are the common cancers, and I'm sorry this slide's a little bit busy, but I've tried to put all of the metrics you might see in the literature to give you a flavour of how they correspond in each cancer. So you can see here with prostate cancer, you might see a relative risk between the top and bottom of 5% as being quite a dramatic risk. That corresponds to an area under the curve of 0.67, and we've talked about lifetime risks already, but you can see the detection rate actually is quite modest, 16% for a 5% false positive rate. And that's the best that the polygenic scores out of all of the cancers can deliver at the moment. And they're the three that, generally speaking, most of the discussions are around by virtue of the fact that they tend to be the most common. So how can we improve on that risk discrimination? Well, the first thing to say is you can generate models which include other things aside from polygenic risk. And the cancer where that's perhaps best described is in breast cancer. And even if you add the polygenic scores to the established non-genetic risk factors, I use non-genetic a bit loosely and I'll explain why in a moment, the improvement in the AUC, I've used AUC because it's just a bit easier here, is quite modest as well. And the reason that's modest is because, well, one reason it's modest is because there's a correlation between the genetic susceptibility to the cancer, but also to the non-genetic risk factors as well. The other way you might want to improve your risk discrimination from a polygenic score is by finding more genetic variants. And actually this was described quite a long time ago by Cecile Janssens before many of the large-scale GWASs were performed. But actually, even if you increase your sample size from your discovery efforts, the improvement in your risk discrimination, again, is fairly modest. So the predicted max detection rate for breast cancer for a 5% false positive rate is around 19%. So the first area where it might be used, and it's been perhaps talked about most, is in screening. And what Rachel Horton and myself tried to do was to try and express this in a way in our paper that's understandable and gives an idea in terms of comparisons to other modalities. And then the next thing to say is that we've chosen to look at areas where there's screening's not currently done at the moment. And that's because it's been suggested in the literature that that's a good idea, and also it's a good way to display these risks and the discrimination. So I'm sure you're all familiar with these 100-person charts, but the red dots will be patients people who have a positive test who develop the disease. The yellow ones are the people with a negative test who develop the disease, so false negatives. And the blues will be a positive test, but they don't develop the disease, so the false positives. And of course, you want to pick up the true positives. The false negatives are the people who you've missed and you've said that they are not at risk of developing the disease. And then the false positives will be the people who you've said they've got the disease, expose them to an investigation or treatment, etc., and then they don't develop the disease. So this is just an example with breast cancer, 40 to 49-year-olds. And screening everyone with a polygenic score. So you can see that you miss most cases in the population and you get a large number of false positives. And we've compared that with doing mammograms for everyone between 40 and 49. And then also polygenic scores, and then the top scores, and then doing a mammogram. So you can see here that even with a polygenic score and a mammogram, you're missing most of the cases in the population, and the false positives still outnumber the true positives. And so there's a lot here, but we've done this in prostate cancer, and the profiles will be different, partly as well related to how common the disease is as well, and in colorectal cancer. But if we just focus on the last bit here, which is doing the polygenic score and then the other screening tests, there's a few takeaway messages. First of all, most cases in the population are missed, and the false positives exceed the detected cases, and that can be explained because most of the disease occurs in people who don't have a high polygenic score. In the example of prostate cancer, combining two tests with limited discrimination doesn't really improve either one of them. If we were to go ahead with this, we'd need significant investment in diagnostics. And concerning some cancers, like prostate cancer, there's still a concern regarding overdiagnosis. So what are the other applications of polygenic scores in cancer? Well, one option is to optimize existing screening. Modeling that's quite complicated. There have been a few small studies that have attempted to do that, and so drawing conclusions is quite limited, but those studies haven't really shown much of a benefit. And the other area is in prevention. So it's important to remember that the clinical value of a polygenic score is dependent on what you're going to do to the person afterwards, and the benefits and risks of what you're going to do to them afterwards. So, for example, with chemoprevention, a lot of chemopreventative agents are likely to carry or will have toxicity associated with it. And so then one has to think, well, you're exposing lots of people, healthy people, many of whom won't develop the disease. You're exposing them to this toxicity. And then with non-medical interventions, things like obesity, smoking, it begs the question, why restrict such public health advice to people when we'd all benefit from those measures? And there are a number of concerns related to polygenic scores, probably too much to go into in great depth, but it will increase the cost of screening programs, the complexity, and may affect the uptake. Limited data to know how much it will affect uptake, if at all. And regarding the cost, one argument used is that it's a one test and you can screen for 8 diseases, but it doesn't necessarily take into account all of the downstream effects for those 8 diseases, further consultations, counselling, further investigations. So it may seem like a fairly cheap cost, but actually there are many consequences from these polygenic scores. The reproducibility of polygenic scores, so what I mean by that is through successive generations of genome-wide association studies, you generate new polygenic scores with different effect sizes, different SNPs. And it's a relatively underexplored area, but there have been 2 papers very recently that have shown that the concordance across generations of polygenic scores is quite low. And that then brings another question. If you've been told you've got a high polygenic score, and then 5 years down the line, a new set of variants come along, and you're no longer in the high polygenic score, what are you supposed to do with that information? Should you carry on with screening? Should you not? These are unanswered questions. Of course, we talked about application in non-European ancestries and the risk that it could widen inequality in these populations. And communication and interpretation of these results is incredibly important. And when we were writing the paper, there wasn't very much evidence either way, but there were a few reasonable studies which suggested there's some significant harm associated with communicating polygenic scores. And not only that, if it's not done properly, then it has the risk of causing significant harm. So to summarize, the risk discrimination offered by polygenic scores in cancer is limited. The clinical utility of polygenic scores is currently unclear, and argue that realistic expectations are needed, and additional studies are needed which not only measure the benefits of them, but also wider impacts and harms from these polygenic scores. And I'd like to thank the funders. So I received a Whitney Wood Scholarship from the Royal College of Physicians to undertake this work, and the people at these institutes, in particular Richard Hulston, Rachel Horton, who's my co-author for the paper, and Annika as well. Thank you very much.